thank you for the introduction, Lindsay. It's a real privilege to talk here for the last Alcohol Occasionals event that's planned before the break. So as Lindsay said, I'm a third year PhD student at the University of Stirling, and I look at how Greenspace programs might be used to support people with problem substance use. So my work is not just specific to alcohol, and a lot of the work that I'm going to talk about today actually relates to both alcohol and other drugs. And my PhD is also not looking specifically at inequalities, but I'm quite interested in the link between Greenspace and inequalities and how that could link to reducing inequalities for people with problem substance use. So this is what I plan to cover in today's webinar. So the first thing I'm going to do is give a really quick overview of Greenspace and pathways for health. So I think this is quite important to provide context of how Greenspace is related to health. I'll then discuss the association between Greenspace and health inequalities and the intersection between Greenspace, health inequalities and alcohol use. I want to discuss that despite there being quite limited evidence actually in this field that Greenspace availability could reduce inequalities and specifically in relation to alcohol use. So I'm then going to talk about how Greenspace programs, rather than just the quantity of Greenspace, could be used to address inequalities relative to alcohol. And then going to talk about a potential framework that could aid implementation of programs for people with problem alcohol and drug use, and discuss some of my work in this area. I'm then going to finish by talking about enduring inequalities for this client group and finish with some takeaway messages. So I'm going to talk for maybe 45 minutes, so there'll be plenty of time for questions afterwards. So firstly, I want to cover what Greenspace actually is. So there's two broad interpretations that are present across the literature. So in some circumstances or some instances, Greenspace can be used sort of synonymously with the word nature and used to describe any type of natural or semi-natural undeveloped land. And the other use of Greenspace is used to describe any type of vegetated land within or in the immediate outskirts of an urban area. So sometimes this is referred to as urban Greenspace. And in the Scottish Government's planning advice note for planning and open space, there were 23 separate types of space identified as a sort of type of green space. So they could potentially be used instead of the term green space. So you can imagine that unclear definitions can lead to confusion. And there's some researchers that say that when you talk about green space or you undertake green space research, you really have to clarify what you mean by that term in each study. That's the only way to ensure explicit understanding. So with this in mind, in this seminar today, I'm going to use the term green space as an umbrella term when referring to all types of green spaces. So whether it's in an urban environment or in a rural environment. And when I talk about specific types of green space or green space programs, then I'll specify and describe these. So I want to really quickly take you through some of the proposed pathways of green space and human health. I'm going to come back to these a bit later on, but I want to provide a bit of context here, as I think that's important to aid understanding. So the first pathway is the idea that green space reduces harm through ecosystem services. And what I mean by the term ecosystem services is the benefits that humans gain from nature and ecosystems. So quickly, two examples might be air oxygenation, so in other words, cleaner air, or climate regulation, for example. So these are like the indirect benefits that humans get or are said to gain from nature and green spaces. And then the next pathway is the idea that time spent in green space restores capacities. So the two leading theories in this, in regard to this, is attention restoration theory and stress reduction theory. So attention restoration theory proposes that nature or immersion in nature facilitates mental restoration, and this improves well-being. Whereas stress reduction theory holds that engagement with nature allows changes in psychophysiological processes. So this leads to reduction in psychological stress and physiological arousal and negative effect. And then the third pathway is about building capacities. So there are two main pathways that are proposed here, physical health and mental health. So in regard to physical health, availability of green space has been reported as an important resource for promoting active engagement, for example, through physical activity and active travel. But then as well as building physical capacities, green space can be utilised to facilitate mental health outcomes. So it's really important here to highlight that none of these pathways are isolated pathways. There's a lot of interlink between them, especially with mental health. really notable interlink between all the pathways together. So I'm going to come back to talking about Greenspace and mental health more specifically later in the presentation. But what I want to focus on first is this general evidence for Greenspace and its role in reducing health inequalities in general. So a recent rapid scoping review of health and well-being that was commissioned by Natural England showed some evidence that green infrastructure, so this is the idea of building with nature or integrating nature into planning and development, has a positive influence on population and individual level health and well-being, and is associated with less stark inequalities in health. But the idea is not new. And Rich Mitchell and Frank Popham published quite a well-known paper in The Lancet in 2008 exploring the effect of exposure to natural environments on health inequalities. And what they found was that health inequalities related to income deprivation in all-cause mortality, as well as mortality from circulatory diseases, were lower in populations living in the greenest areas. And their takeaway message was that environments that promote good health might be crucial in the fight to reduce health inequalities. And I'll draw on some of their work in a wee bit as well. But one of the newest systematic reviews published this year by Alessandro Rigolon and colleagues explored the potential reduced inequalities, and what they found was people from more deprived areas gained more health benefits compared to affluent people, particularly when concerning public green spaces and parks. What was interesting, though, was that they found that this was much stronger in Europe compared to the States, which starts to suggest that context matters. So, for example, the authors suggested that systemic racism and police harassment and discrimination experienced in parks in the United States could play a part, or Europe's public healthcare systems might push some countries to invest in more upstream health interventions, or perhaps green space is higher quality in Europe's lower socioeconomic neighbourhoods compared to the States. So this idea of lack of or poor quality green space can actually further affect inequalities. So, for example, in another study by Nam and colleagues, they concluded that tree canopy was 17% lower in the most deprived areas in areas of the United States compared to the least deprived, and exposure to airborne carcinogens was 3 times higher in the most deprived areas compared to the least deprived. So how does this all link to alcohol? So going back to what I briefly said at the start, there's actually very little research exploring this, but what I'm hoping to do is explore how this idea of green space mitigating some of the health inequalities experienced by people with problem alcohol use is feasible. So firstly, we need to think about the link between alcohol-related inequalities and lower socioeconomic status. So we've seen from global data that people in richer countries are more likely to drink alcohol and overall have higher rates of consumption. And Scottish and British data also show that those in more affluent areas are likely to drink more alcohol or the same amount as people in more deprived areas. But this doesn't mean that the harms from alcohol are less in deprived areas. In fact, it's the opposite. So Jennifer Boyd, who spoke here at Alcohol Occasionals a couple of months ago, she spoke about this idea of the alcohol harm paradox, the idea that those in more deprived areas tend to experience greater alcohol-related harm than those of a higher socioeconomic status, even when they drink the same or less amount of alcohol. So if you have somebody in one of the most deprived areas drinking the same amount of alcohol compared to the least deprived, then that person in the deprived area will experience far more harms, including ill health and early death. And in Scotland specifically, alcohol-specific deaths are 7 times higher in the most deprived areas in Scotland than the least deprived, and alcohol-related hospital stays are 8 times higher as well. So if I draw back on the example I gave a few slides ago of green space and reducing health inequalities in those with a lower socioeconomic status, Rich Mitchell and colleagues identified that socioeconomic inequality in mental well-being was 40% narrower among study respondents who had good access to green space compared to those with poor access. But also what was interesting is that no other neighbourhood characteristic was in their study was associated with reducing health inequality. And also their study was based on data for 34 European nations. So it was quite a large study from different areas as well. And this idea of the features of the environment acting to create health equality within the confines of existing material inequality is referred to as equigenesis. And what is further interesting is that time spent in green space appears to be more beneficial for those in more deprived areas compared to affluent areas. And this has been shown by quite a few studies now. So taking this and relating it back to alcohol, if people with a lower socioeconomic status are at a higher risk of alcohol-related harm, but if Greenspace is successful in reducing health inequalities for people with a lower socioeconomic status, then it's feasible to suggest that Greenspace could be a protective factor in mitigating some of the health inequalities experienced by people with problem alcohol use in more deprived areas. But as I said, the issue being that there's actually very little research of that intersection at the moment. But looking more specifically at mental health, there's a well-documented link between mental health and alcohol use. Some people drink alcohol to cope with previous trauma, poverty, existing trauma, and challenging life circumstances, for example. There's evidence that suggests that stress and distress of COVID has led to higher levels of alcohol consumption in some people as a way of coping. Despite using alcohol to cope with stress and poor mental health, on the other hand, alcohol use can also exacerbate mental health challenges. So again, thinking back to the presentation when I first introduced the pathways, evidence shows that Greenspace allows decrease in stress and improvements in mental health. In a recent study by White and colleagues, they found that people who spent at least 2 hours in nature per week were consistently more likely to report higher levels of health and well-being compared to people who spent less time in nature. But what was perhaps most important in this study was that the pattern of a 2-hour threshold was present for nearly all groups that were looked at. So older and younger adults, men and women, people in cities, rural areas, people in deprived, people in wealthy communities, even people with and without long-term illness and disability. So what this suggests is that the results are not merely due to reverse causality. So the idea that people who visit nature are already a self-selected sample of healthier people, because even those with long-term illnesses were more likely to report better health and well-being if they spent 2 hours a week in nature. So there's a vast number of studies that now show a link between Greenspace and mental health, both in the UK and internationally. Research has explored the relationship between Greenspace and mental health in lots of different domains, as I've written on the slide here. So subjective well-being, depression, anxiety, general mood, self-esteem, and others. In Scotland specifically, the Green Health Project was designed to explore the relationship between Greenspace and mental health. And one key finding of this study was that people who lived in urban areas and who used green space such as woods or forests for physical activity had a lower risk of poor mental health than people who did not use these green spaces. But also use of outside areas such as woods and forests appeared to be more effective in improving mental health than use of the gym when doing similar activities. Excuse me. From the international literature, so in some parts of Asia, for example, like Japan and Korea, the concepts of forest being healing environments is really ingrained in their culture, with the idea that through immersion in forest, stress is reduced and well-being increased. So this is referred to as forest bathing or Shinrin-yoku, and is actually growing in popularity here. So you may have heard of it and you may have experienced it yourself. But what's been shown is that green space is in fact more beneficial for people with poor mental health compared to those with positive mental health. This has been shown in various studies, looking at walking outside in rural compared to urban areas, green exercise in different environments, and various other green health activities. So if green space improves mental health, particularly for those with poor mental health, could there be a subsequent effect on the use of substances? So if green space improves health, could there be a preventative effect on substance use? So just to recap over the last 4 slides, overall alcohol harm is higher for people from lower socioeconomic backgrounds and for those with poor mental health. If green space is shown to contribute to health, particularly from those from a lower socioeconomic background and those with poor mental health, then it seems feasible to suggest that increasing opportunities for engagement with green space could play a role in mitigating harm and reducing health inequalities for these groups. So how does exposure to green space actually reduce inequalities in the first place? So in a paper by Becca Lovell and colleagues that explored improving access to green space, the authors discussed the ways through which green space could promote positive health and well-being outcomes. So the first thing they spoke about was physical activity. So this is linked to positive health outcomes of many types. Green space can support higher levels of physical activity. There's indications that people may enjoy and more likely to repeat an activity if it takes place in a natural setting compared to inside. The National Institute for Health and Care Excellence suggests that green space should be used whenever possible to support people of all ages and all abilities to undertake physical activity and improve their health and well-being. and reduce the need for direct, more costly interventions. And then secondly, recreational activities. So the activities that people do in green spaces, not necessarily high activity like physical activity, but even things like enjoying the scenery or walking the dog or relaxing, has been shown to positively impact mental health. And evidence is really still evolving in this area, but there's indications of positive impact of outdoor recreation, including things like improved self-perceived competence, things like learning and identity, positive well-being, and increased family cohesion as well. And then nature connection. So some evidence indicates that people who feel more connected to nature tend to have a more positive outlook on life, increased vitality, increased life satisfaction, feelings that life is worthwhile, and of personal growth compared to those who feel less connected. And then community and social cohesion. So reviews have shown that green space can reduce isolation and the loneliness by providing the opportunity to participate in shared social activities. Again, this leads to greater social cohesion, in turn leading to better mental health. And then finally, mediating potential harm through ecosystem services or ecosystem benefits. And as I spoke about earlier, these are the passive benefits of green space for example, things like air oxygenation, noise reduction, even climate moderation. These are all things that affect health, and evidence shows that greener areas are linked to higher levels of ecosystem benefits. However, of course, there are potential barriers that may limit these mechanisms, particularly for people with problem alcohol use, for example. And I'm going to come into that a bit later on as well. But for now, I want to talk a little bit about green space intervention programs. So as well as availability of green space, so things like walks in the park and general immersion in nature, another way green space is used is through green space programs. And what I mean by a green space program is a health intervention typically undertaken outside in a green area. So other terms can be used, for example, green space intervention, nature-based program, nature-based intervention, green health program, for just a few examples. And green space programs can provide a range of social and health benefits. There tend to be three basic types of interventions. So firstly, those that increase the amount or quality or improve accessibility to green space, those that increase use of or engagement with natural environments, and thirdly, those that use targeted health interventions based in green space. And it's really this third type that my work focuses on. So for these more targeted health interventions, many settings have been used, for example, public parks, woodlands, rural settings, private gardens, allotments, community gardens, farms, and others. From a mental health perspective, they incorporate many factors that allow a person to effectively build capacities in factors such as social cohesion and interaction, self-efficacy, learning new skills, for example. So I'm now going to talk through just three common types of green space programs. There's lots of different types though, and many green health organisations will use a variety on their programs. So therapeutic horticultural programs, they're seen across the UK, commonly undertaken in specialised gardens within residential care, hospitals and rehabilitation facilities, for example. And the gardens offer people a chance to participate through therapeutic hands-on green activities and by spending time in green space. And they also provide a supportive social environment and this chance to build relationships in what is being referred to as a non-threatening atmosphere. And wilderness and adventure programs, they typically utilise larger areas of green space. Interventions are often residential programs, often developed for adolescents and young people as a way of sort of promoting recovery through removal from high stress or chaotic environments. And it's this feeling of kind of being away, that as well as learning new skills and the restorative effect of nature. They're often reported by participants as being particularly important factors in the success of these programs. And then care farming is the use of regular farming activities to promote mental and physical health. These are usually based on a commercial farm or actually any other type of agricultural landscape. It's estimated there's over 240 care farms in the UK, over 8,000 people using them for some type of support. I would have thought that numbers have probably increased over the past year as well, potentially. The range of support that care farms provide runs on a continuum between just passively providing a therapeutic environment and providing more structured programs. So like I said, these are three examples that I've given that are seen across the UK. But green space programs can also be community-based groups, things like health walks, for example, green gyms, football groups, conservation groups, etc. There's a really wide range of activities that can go on and can be called Green Health. So Green Health partnerships in Scotland, funded by Nature Scot, have developed various green health referral pathways that enable Greenspace programmes within the community to contribute to primary prevention and the maintenance of both physical and mental health. And participating in these green health programmes, I guess, transforms the common approach to prevention and treatment and recovery of ill health. It can also improve treatment success in people who have already developed mental health issues and help with their recovery. So this is a diagram showing how this idea of Greenspace and Greenspace programmes, referred to in this diagram as nature-based interventions, can complement the NHS to achieve health outcomes. So you can see in this flow diagram that it shows how Greenspace can be beneficial within the general population, as well as for people with a more defined need. In some parts of the UK, a formal pathway has been developed alongside the medical prescribing pathway to connect NHS primary and secondary care with nature-based interventions through this green health prescription pathway. So a physical prescription is given to suitable patients to connect them with local nature-based programmes. Patients receive this person-centred consultation with a dedicated green health worker to find an activity that is most suitable for the service user's need. So this picture on the slide is an example of a green prescription from Dundee. And in Scotland, green prescriptions have been implemented so far in Dundee, Edinburgh and Shetland for a variety of different conditions and different client groups. So how can Greenspace programmes for substance use reduce inequalities? So they can be used with a prevention focus with young people who have a higher risk of substance-related harm. For example, Young People's Wilderness Adventure projects. Organisations such as the Venture Trust, Venture Scotland, among others, have worked with young people, not just with a focus on substance use, but using a holistic approach to support them with their lives. And Greenspace is really central to their work. And Greenspace programmes can meet people where they're at. So one of the key benefits of Greenspace programmes as an intervention for people with problem substance use is that they can provide support for people without placing any demands or expectations on them. So many programmes typically don't require abstinence, or they don't require a commitment to reduce substance use. Of course, some programmes do, but many don't. So this could improve access onto programmes or access into support. And often the programmes are supportive without falling under this typical banner of treatment, which potentially removes the stigmatisation and medicalisation that can sometimes be seen relative to substance use treatment. So they can also run alongside other substance use services. For example, Phoenix Futures have their Recovery Through Nature programme, which runs as part of their wider support. So it's really important to note here that Greenspace interventions don't claim to be a panacea, but they could be a feasible addition to a package of holistic care and could signpost to other specific substance use and or mental health services. While there's an increasing number of Greenspace programmes that are being developed, there's still actually a limited understanding of the key components and the processes that actually go into making these programmes successful. And this makes it quite difficult to develop and implement new projects or new programmes and evaluate them successfully. Also, a better understanding of the processes within a programme may increase the likelihood of engagement with programmes from a client's point of view, interest in programmes, but also buy-in from stakeholders, those working in primary care, for example, like GPs, who may be the ones actually referring clients in circumstances like green prescribing. So the question really becomes, what are the mechanisms that lead to the outcomes? And this is where my work is situated. So for the first phase of my PhD, I undertook a review of existing literature and used a realist approach, which in comparison to many evaluation types is not about focusing on if something works. It's instead about creating programme theories about how interventions are meant to work. So realist approaches hold that outcomes of interventions like Greenspace programmes are achieved through underlying generative mechanisms, which are present in the right context. And I've used this word mechanism quite a few times in my presentation so far, but what I mean by it is that it's the causal aspect within a programme that leads to the outcomes. So I guess it's the why an outcome happens. And these responses are influenced by context, so the factors that make responses more or less likely to happen. And context can be individual, interpersonal, organisational, institutional within the programme setting. So a realist evaluation establishes causality between a programme and an observed outcome by focusing on this context mechanism outcome configuration. which is also referred to as a program theory, which is literally the theory about why a program works. And each program and intervention is made up of a number of program theories, which are refined through the evidence provided in the data. So this area of work is developing all the time, and there is actually a lot more evidence than now than when I did it a couple of years ago. But when I undertook the review, there was quite limited empirical evidence regarding Greenspace programs for supporting people with problem substance use. So the review actually focused on Greenspace programs for mental health more generally in clinical and non-clinical populations. And what we then planned to do was develop program theories and a framework for these programs, then at the next stage, test it to see if it was also applicable for Greenspace programs that support people with problem drug and alcohol use. So in the review, 49 full-text articles were synthesised. Ongoing conversations with Greenspace organisation staff was held throughout the search and appraisal process. And using the data, the context and the mechanisms and the outcomes were combined into 7 program theories. And the 7 program theories were combined under 3 themes of nature, individual self, and social self to provide a sort of overarching theory or framework. So we found that there were 3 themes, as I've just mentioned, that all the components seem to fit into. The components that to do with nature, which are the red row, components to do with changes in a person's individual self, which is the yellow row, and components to do with the wider social self, so things like the grey row. So things like changes in peer relationships. And the program theories are listed on this graphic as numbers PT1 to PT7. But the titles are fully explained in the paper, which I'm going to link to at the end so that you can see the graphic just in a little bit more detail than you can see on the slide. But the first program theory was looking at the feeling of escape and getting away from daily stressors. Program theory 2 was having space to reflect. Program theory 3 was increased physical activity. Program theory 4 was increased self-efficacy with new skills. Program theory 5 was having a purpose. Program theory 6 was about relationship with the facilitators. And program theory 7 was about shared experiences within the group. And it's these headings of the theories that I think really show what some of the kind of key aspects are in regard to Greenspace programs. And it's these mechanisms in the middle column. These are said to be, I guess, the key ingredient, if you were, that leads to outcomes as long as they happen in the right contexts. And these are the components overall that we found make Greenspace programs successful for mental health. So some of the things that lead to outcomes in relation to nature quickly are the feeling of being away from daily stressors, connection to nature, and time alone to reflect. Some of the things that lead to outcomes in relation to the individual are enjoyment of activity, self-efficacy, feelings of purpose, feelings of routine. And then some of the things that lead to outcomes in relation to social self are trust in others, decreased power inequality between the facilitator and client, feeling safe within the group, and shared experiences. But these are really just some of the mechanisms that lead to these optimum mental health outcomes. There's also additional influencing factors. I've not included this on the slide, but they are in the wider model. So again, if you are interested, then I'll provide the link at the end and you can have a look at that. So how does this relate to alcohol and other drug use? So what we then did was to take the framework forward to see if it was applicable with programs that support people with problem alcohol and drug use, and therefore show that mechanisms that lead to beneficial outcomes, so then programs can be effectively developed for this client group. But what justification did we have to do this? To answer this, you really have to think about the link between mental health and substance use, which I spoke about very briefly earlier. The link between mental health and both drug and alcohol use is well established with previous systematic reviews and meta-analyses reporting a strong association between the two. So the question becomes, if Greenspace can improve mental health, then could it reduce substance use or at least support people with problem substance use through similar causal mechanisms? So the second phase that was looking at if the framework also works for programs that support people with problem substance use. And there are successful programs that exist for this client group, but actually, again, very little understanding of the causal pathways. So we distributed a survey to Greenspace organisations in Scotland to test the framework in the study before, and basically ask participants to what extent they agreed with the framework components. So there was responses from 55 organisations from 10 different regions in Scotland, which is actually fairly high. All programs supported clients to improve or maintain their mental well-being. Approximately 36% of programs supported people with problem alcohol and illicit drug use. Just over 39% did not support people with problem substance use of any kind. There was a wide variety of types of Greenspace used, so some were urban, some were rural, and results showed a really high level of agreement overall with the framework in all organisations, including those that supported people with problem substance use. So what this means is that the framework seems to be applicable to both Greenspace organisations specifically for mental health, as seen in the review, as well as Greenspace programmes that support people with problem substance use. So this framework could then inform future programme implementation. So we've written this up as a research paper and it's currently under review. So what I want to talk about now is some of the evidence from the Greenspace programmes directly themselves, people that work on the Greenspace programmes. And this is the work that I've done with interviews in phase 3 of my project. And the aim of this phase was to further test the framework. But what I want to try and do today is show a little bit about how health inequalities could be addressed by these types of programmes. So in terms of my method, I conducted qualitative telephone or Zoom interviews with staff on Greenspace programmes, researchers within the field, and relevant wider stakeholders, so people involved in green health partnerships, green prescribing, and other people whose work is related to green health. I interviewed 12 participants in the first stage and then interviewed 5 participants in the second stage of interviewing. In Realist research, this is referred to as a consolidation phase, so the final testing of the framework. And I wanted to interview clients on the Greenspace programmes, but many programmes were stopped because of COVID, and I wasn't able to work on the programmes themselves. And even the ones that were open, ethically, there were issues there because there were limited spaces, limited places, and strict social distancing measures. So me being on a programme would take the place from somebody else who could be on the programme actually benefiting from it. So this is work I really hope to do in the future, because it's really important to me to include clients' voices, but that's why it's not involved. That's why it's not part of this this study. Unfortunately, I think that's a really important thing to kind of get across, like why they're not involved. So I just want to read through some of the findings in regard to reducing inequalities. So in relation to reducing inequalities relative to the community, some of that community stuff, feeling valued, feeling part of society again for the first time, perhaps in 20 or 30 years, that is directly related to being outdoors and utilising that green space down at the allotment. To come from such a stigmatised, sort of isolated, lonely place of serious addiction to actually feeling just part of the community that you live in through the gardens is absolutely amazing to see. And taking part in these types of things, they then start to feel quite a bit of pride in the community. They feel as if they've got something to offer. They sort of value themselves a bit more than they originally did to begin with. They're feeling included. They actually feel like they belong to something, so they feel like they matter all over again. In relation to access to services or service approach, when you're outside, there are less agendas or less pressure. I think when you're sitting and you're talking in that setting, when it's a one-to-one setting and you've got 2 people sitting opposite each other, they're in a chair, they're in a room, it could sometimes be a bit daunting to open up. I think part of that is about the garden being a non-medicalised environment where you're not using the labels that are given to people around whatever their mental health challenges are. This is the other thing about gardening. They're all in it together and we're all learning together. That kind of is a nice way, that is kind of a way of neutralising power dynamics. And I think is a really nice space for people that often feel like their voice isn't heard a lot in their day-to-day. In comparison with clinical appointments where I've met people in an office environment for around 45 minutes or an hour, it's the natural setting, the reduced sense of the power balance really between the professional and the clients. It felt like a much more equal footing for the client to attend. And then in regard to relationships, so relationships were mentioned a lot by interviewees, which is probably not surprising. So we don't ask people to do stuff. We do stuff with young people. So if we're building a raft, we're all building a raft. If we're going to jump off something, we're all jumping off. It's that level playing field where we try and level up the client facilitator thing, involving them as much as possible and allowing them just to take ownership of the actual journey that they're on, rather than just being, kind of like a boot camp type thing where they're there and they're kind of told what to do. And we come at it the wrong way. We try and get the person to stop doing something that they need to do without replacing it with something that might tick the same box. Where I guess the idea of Greenspace programs, it's like, let's just do some stuff and get connected and build relationships, build huts, build bivouacs, do what you like. But fundamentally, what you're really doing is building connections and building relationships to the point where if you do it long enough, the substance use might take care of itself because other things have taken its place. So for the last part of the seminar, I want to talk about Greenspace and sort of enduring inequalities. So if you think about the fact that nature and green spaces are free to use for the most part, they're around a lot of us, and there doesn't seem to be any reason why people can't use them. So is access actually equal? And I'm sure you won't be surprised to hear me say that they're not, and current provisions of Greenspace are not equal. Those who may benefit the most, for example, people with problem drug or alcohol use, are often at disadvantages in terms of both access to both quantity and quality of space. So, for example, the availability of green space differs depending on where you live. Affluence can allow people to buy homes that in areas that have got more green space, better air quality, more space for physical activity. But while there are many green spaces in some deprived areas, overcrowding can be an issue. It's often seen at a higher rate in deprived areas. This means that the number of people who are potentially using each available green space is higher compared to in more affluent areas. So even if there is green space, there's more people using it. Crime levels and litter, for example, could be issues. And inequalities in access to green space actually became even more apparent during the COVID-19 lockdown. And one study highlighted that around 13% of people in England and Wales live more than a 10-minute walk from their local park. So when walking in local parks and other green spaces was deemed essential for mental health during the pandemic and lockdown especially, those that live a distance away are at clear disadvantage. And another recent study by Hannah Burnett and colleagues in Glasgow showed that use of green space reduced during COVID, possibly due to a number of reasons. For example, people were anxious about leaving home, particularly those who were shielding. Also, those who were working frontline possibly had less time to visit. Women and older adults were less likely to visit green spaces too. So you can see that there's really kind of enduring inequalities there in terms of people and access and people who can access it. And also, while green infrastructure can reduce inequalities in health, it's likely over-reliant on the assumption that green infrastructure is equal across communities, which isn't the case. And furthermore, poorer quality green infrastructure can actually exacerbate inequalities. There's also evidence that new or renovated green infrastructure can actually exacerbate inequalities as well through processes such as gentrification. So green space and green infrastructure can actually make communities more expensive, which negatively affects the people who live there. So this sort of goes against the idea of a win-win idea of if you increase green space, then you increase health or reduce inequalities. So it's not quite as straightforward as some of the things that it might seem. And inequalities in access are also seen relative to specific green space intervention programs. So programs are designed to improve health outcomes, but attending these programs can be reliant on practical but often overlooked aspects that can create barriers. For example, particularly for people with problem substance use. So examples include the cost and the ease and the safety of travel, the cost of owning the correct clothing and footwear, particularly since COVID and no longer being able to share or borrow items, things like caring responsibilities, physical capabilities and general differing personal circumstances can present inequalities as well. So mobility issues may limit people's ability to take part in more physically demanding programs. Wilderness projects, for example, might not be appropriate for people who've been involved in offending and have an electronic tag, for example. And even things like court dates should be taken into consideration to ensure that the program doesn't affect these. Medication and treatment needs as well have to be taken into consideration, those on a daily pickup prescription or those undertaking a detox, for example, then it's probable that a number of these types of programs are not going to be suitable for them. Also, wilderness projects might not be appropriate for people with certain conditions, for example, psychosis. So previous experience is also a potential barrier, which may mean that some people are less likely to take part. So some people that have had less experience with nature or being outside in nature have been shown to be less inclined to take part or being interested in programs. So they may require somebody to go with them, so like a support worker or a buddy to go with them. So this actually happens across Dundee in the Green Health Partnership scheme there. Also, if a person has negative experience with treatment services or being let down by safeguarding, then this could affect their engagement as well. So if a person has negative experience and has been let down by the care system, the criminal justice system, other health services, then why would they trust another programme? So programmes really have to work in a trauma-informed way to address this and ensure that that isn't just a buzzword. But more positively, here are the sort of key messages, I guess, from my work. So the integration of Greenspace into mental health strategies could be important, given that mental health concerns are increasing, which suggests a need to find ways to support the rising demand while limiting rising costs. So they could have a prevention role, something that there's quite a lot of interest in just now with rising substance-related harm. But they also have the potential to meet people within the communities and where they're at. So whether they've got a goal of reducing their alcohol use, for example, or whether that's not their goal, the support is there in lots of different areas. These types of interventions can fit into wider policy landscapes, and the climate agenda, for example. Increasing or maintaining green space is essential in the fight against climate change. They can run during COVID when many other services had to shut. Interesting, the BPS updated their guidance about outdoor talking therapy quite recently, which shows this move outdoors within more mainstream services. And as I hope some of the quotes showed, they can reduce key inequalities, for example, in relation to improving engagement with services, reducing stigma, improving relationships, and integration back into the community. But what is essential to take from this talk, in my opinion, is that these interventions are not a substitute for care. They're part of a holistic care, and they can potentially allow outcomes which other treatments don't, whether that's changes in relationships, empowerment, reduced stigma, reduced power imbalances, on top of the therapeutic effect of nature itself, such as the feelings of escape or stress reductions and a connection to nature. But as I mentioned previously, they're not a panacea for all. And I think that this final quote really represents this idea quite nicely. So I'll just read it out. I like the idea of these programs contributing to wider systems of care. So they are not seen as the thing you do now, and then something else will come up at the end. You know, they're part of a package of care to whatever degree they need, and it contributes to care rather than it is the care option. So that's me. Thank you for listening to my presentation. Here are my contact details, my email address and my Twitter handle as well. Also the link to the Realist review with the framework, and goes into it in a lot more detail than I was able to in this presentation today. And also the link to a conversation article that discusses green space and health inequality.